Dr. Gopal S Pillai, my co-instructor, who is also the Principal Investigator for BIRAC, a project by central government to establish clinical trial network for hospital-based clinical trials in ophthalmology, will be speaking on the new Anti VEGF agents. Gopal.
Hello all. Let me thank Dr. Srini Daklon for providing an opportunity for me during this symposium. So let me share my screen. We are looking at who is the new Anti VEGF who has taken the field of medical retina by storm, who is a new kid on the block. Let us see. As we know, AMD is a leading cause of severe and irreversible vision loss, affecting about 13% of adults over 65 years, and about 300 million people will be affected by about 2040. As you can know, our India also has significant increase in aging population. There are a lot of unmet needs when patients with neovascular AMD. One is unresolved fluid, the other one is high injection burden. So many people, more than 50% of people, even after 2 years of continued treatment, have residual fluid, and there's a huge number of people who require more than 2 monthly injections. And so many people are non-adherent to treatment because as the number of injections increase, they will find it financially and otherwise also very difficult to continue the treatment. And that is when there is a relevance of retinal fluid in neovascular AMD. As we all know, there is intraretinal fluid, which is within the retina, subretinal fluid, which is between the retinal pigment epithelium and the sensor neural retina, and sub-RPE fluid, which is below the retina, which is seen in occult CNVMs. So these are the 3 levels of fluid. And fluid is a component of neovascular disease activity, is very, very important. As you can see in the CAT trial, about 1,000 patients were analyzed and 82% of people had subretinal fluid. About 3/4 of them had intraretinal fluid, and sub-RPE fluid was seen in about 50% of patients. And in the real world, actually what drives our treatment? The injections are driven by the presence or absence of fluid. The presence of subretinal fluid or intraretinal fluid was at least 4 folds in times when injections were needed. And whenever there was fluid, there was a consistent visual loss also. Absence of intraretinal fluid or subretinal fluid leads to better visual acuity, as you can see in this particular graph. The visual gains are seen in patients who do not have subretinal fluid. And as you can see here, if there is fluctuation of fluid volume over 2 years, then there would be much more poorer visual improvement. Those people who had a sawtooth OCT, like there was an increase, there was a decrease, there was an increase, there was a decrease, would have poorer visual outcomes as compared to people who had a stable OCT reduction. Now we come to Brolucizumab, the most clinically advanced single-chain antibody fragment. You can see that there are 2 FAB domains and a FC domain. And you can see that they are packaged, and the clinical regions are the antibody that form the antigen binding site. And that is a scaffold which are there. So you join them to form a Brolucizumab. It is more drug in a single injection. It's a potent inhibition of VEGF-A. It will cause effective penetration into the retina and rapid systemic clearance. Let us look at each of these things. If you look at aflibercept and compare it to Brolucizumab, it is 11 times the number of molecules per injection. And as compared to ranibizumab and Avastin, we have about 25 times the drug concentration is achieved because it is a much smaller molecule and its molar concentration is very high. This is how Brolucizumab will achieve more drug per dosage. Now looking at VEGF-A inhibition, you can see that the affinity is a strength of binding, and affinity is measured by the equilibrium dissociation constant. And that is very, very highly placed for Brolucizumab as compared to others. Now, what about effective penetration of the retina? The more molar concentration of the smaller molecule makes the effectiveness into the penetration into the retina much rapidly. you can see that within 1 hour, the Tmax in retina is about 1 to 6 hours in brolucizumab as compared to 6 hours in ranibizumab and about 24 hours in aflibercept. Now you can see that the penetration into retina is much more rapid. It is readily distributed from the vitreous into the retina very rapidly and significantly. And also, there is a very rapid systemic clearance, which makes all the side effects much less. So retinal exposure is high, yet systemic exposure is low. Now let us look at how it affects the fluid. HAWK and HARRIER were 2 studies in which brolucizumab was compared to aflibercept. After the loading doses, 3 monthly brolucizumab was compared with 2 monthly aflibercept. So that was the difference. So one was 12 weekly injection, other was 8 weekly injection. And you can see the results. So brolucizumab 6 milligram was almost equivalent to aflibercept, even though the number of injections was much less. In a year, you required 4 injections. And in these 4 injections, the effect of brolucizumab 6 milligram was almost equivalent to aflibercept. And this also shows us the reduction in the central subfield thickness. So even till week 96, you can see that the central subfield thickness was significantly low. The fewer patients on brolucizumab had intraretinal fluid or subretinal fluid. You can see that, compared to aflibercept, all the patients with brolucizumab had significantly low numbers of people with fluid in the AMD, which is a very important marker of repeat treatment. In both HAWK and HARRIER, fewer patients had sub-RPE fluid on even up till week 96, and 6 milligram patients maintained on 3 monthly dosing interval up till week 28. Similar was in polypoidal choroidal vasculopathy. This is the Japanese population who had significant PCV. You can see that brolucizumab 6 milligram was much better than the other groups. You can see the equality in terms of 12-week dosing as compared to 8 weekly dosing of aflibercept. So we can see that aflibercept, about 90% of brolucizumab 6 milligram patients successfully completed week 48 on 3 monthly injections. And these are the submacular thickness as well, significant reduction, presence of intraretinal or subretinal fluid. 12 weekly, which means 4 injections a year, can have wonderful results. And to summarize, all fluid is pathological. Fluctuations are bad. In both HAWK and HARRIER, fewer patients on brolucizumab had IRF or SRF, and even that can be there in the PCV, and about 3/4 of 6 milligram brolucizumab patients were maintained on exclusive 3 monthly injections. Thank you very much for your patience here.
Thank you, Gopal. That was a great presentation.